It has been 1.5 weeks since you started your internship. Your senior resident has been pushing you around and making you do so many admissions until now. I don't know if this made you stronger or weaker. Anyhow, it's Wednesday evening, 4 p.m. It's time for you to go home, but he calls you up again and tells you, you know what, I have another admission for you. And the case goes like this. A 35-year-old male with a past medical history of chronic alcohol abuse with multiple previous admissions for acute alcohol intoxication and alcohol withdrawal, now present with acute severe abdominal pain for the past 1 day. The patient was drinking alcohol with some friends when his symptoms started. The pain was so unbearable and was associated with nausea and vomiting. So he called EMS and came to the hospital. Alright guys, so based on the history that's presented to you, you have a guy who's coming in with a severe abdominal pain for the past 1 day, and he's been drinking a lot of alcohol during this time. Now he also has a lot of history of multiple hospital admissions in the past for alcohol intoxication as well as alcohol withdrawal. So you clearly know that this guy does have an alcohol problem. Alright, fine. Now he's coming with abdominal pain, so obviously you probably have some differential diagnosis in your mind already, right? Such as gastritis, acute pancreatitis, maybe there's cholelithiasis, right? All these differential diagnoses automatically should come into your mind the moment you hear about this patient's case. Alright, however, the way you're going to work this patient up is in the following manner. So based on the history, clearly you guys have a suspicion for acute pancreatitis, and that is in fact going to be our topic of interest for today. Now, the way you're going to deal with the patient with acute pancreatitis is you need to know what to look for and what to ask the patient in order to know what you're going to be finding. So the way we're going to deal with this is, first off, let's try to break it down and think about what are the possible causes that would cause the patient to have acute pancreatitis, right? The moment you know what causes acute pancreatitis, clearly you know what to ask the patient. So let's look at this beautiful picture that I've got on this board to find out what is really going to cause acute pancreatitis. Alright, so first off, as you see here, this is a bottle of alcohol. Nobody sells alcohol saying ETOH on it. They actually have brands and whatnot. I'm pretty sure you guys already know about that, but the important thing for you to note is in fact going to be ethanol. Alright, so I'm going to put number 1 for ethanol. That's important. It's one of the most important causes to actually give you acute pancreatitis. Now apart from alcohol, another one who's also going to get number 1 is going to be your gallbladder. Look at this patient's gallbladder. What do you see? Do you see nice circles, little balls within this patient's gallbladder? Yes, you do, right? Normal gallbladders are not supposed to look that way. What does this patient have? It is gallstones, guys. Gallstones and alcohol are the most common causes for acute pancreatitis. Once the most common ones are done, now you can move on to the rest of them. So what are the rest of them that you actually have to ask the patient about? Now look at this beautiful burger that's often sold in McDonald's or some other form of fast food chain. It always is going to say a lot of triglycerides, right? You're eating a big burger, juicy burger is going to have a lot of fat. So think of fat, alright? Specifically what I'm interested is in fact going to be triglycerides. So triglycerides is an important cause for acute pancreatitis as well. Alright, then you got this medication box here. This is a normal medication box that's often carried by older people since they've got so many medications to take. They number them from Monday through Friday. So however, you're going to remember this box, and I want you to focus on these medications that can give you acute pancreatitis. They are furosemide, didanosine, mesalamine, hydrochlorothiazide, and simvastatin. You guys already know where you're going to use this medication, and these are just a few of them. There are many others, alright? But important thing is remember to ask about the drugs that the patient is on, because those can be contributing to the patient's acute pancreatitis. Alright, let's move on over here. What do we see? Now we see that this patient's got a really large bicep. I'm pretty sure this guy works out, but nobody gets biceps like that by just working out, right? He's probably taken some form of steroids. Now steroids by itself can also give you acute pancreatitis. Not very common, but still it can give you. So steroid use, it's not just the injected steroids, it could be patients who are on chronic long-term steroids as well, but steroids can give you acute pancreatitis. Nextly, let's go to the patient's forearm. What do you see? You see one bone in there, right? Normally in a forearm you're supposed to have ulna and radius, but the reason I drew only one bone is to show calcium, right? A lot of calcium in the patient's body, the bone for calcium, right? So calcium, hypercalcemia can give you to have acute pancreatitis. So that's going to be another important cause. Okay, now apart from that, clearly this patient is getting punched on his face, so trauma not to the face but to the abdomen, can give you acute pancreatitis as well. Now you see the parotid gland is swollen. Who causes parotid gland swelling? It is going to be mumps, right? Mumps is another important cause as well. And last but not least, you must also remember ERCP. Patients undergoing ERCP can also develop acute pancreatitis. So you want to ask this patient in the history, did you have a recent ERCP done, right? And apart from that, finally you have autoimmune pancreatitis as well. Again guys, these are the causes for acute pancreatitis, but the most important ones is in fact going to be alcohol and gallstones. So you must remember those two, and the rest of them are other important causes as well, but not so common like the first two that I've mentioned. So once you know what the causes are, clearly you already know what you're going to ask the patient. You're going to ask the patient, okay, do you have these risk factors, right? So that's most important. So you know the causes now. Now the next thing is you need to be able to tell me, all right, this patient definitely has acute pancreatitis. So what is your criteria? What is the criteria that defines acute pancreatitis? Diagnostic criteria for acute pancreatitis. Basically, there's just 3 important points for you to remember. That's it. If anybody ever asks you what is acute pancreatitis, how are you going to tell me that the patient has acute pancreatitis? You're going to tell them, listen, I'm following guidelines, and that's exactly how you're going to tell them that the patient has acute pancreatitis. So point number 1 is the patient's going to have a characteristic acute abdominal pain that is resembling acute pancreatitis, which is going to be a deep epigastric or a mid-abdominal pain with radiation to the posterior, right? This kind of classic pain is going to be representative of acute pancreatitis. So that's your point number 1. If your patient has a characteristic pain, then that's point number 1. Point number 2 is elevated enzymes. The enzymes you're specifically going to look for is amylase and lipase. Which one is specific, guys? It's going to be lipase, all right? Amylase is non-specific, but you can still look for it. However, you're going to look for amylase or lipase, and you need it to be more than 3 times the upper limit of normal. All right, it needs to be more than 3 times the upper limit of normal. All right, just a mild elevation does not meet the criteria. Number 3 is going to be CT evidence of acute pancreatitis. So a CAT scan evidence of acute pancreatitis, it could be present. So how many of these criteria do you need to tell me that the patient has acute pancreatitis? It's going to be 2 out of 3. That's it. If you have any 2 criteria, you have a clinical diagnosis of acute pancreatitis. A clinical plus a lab, right? That's alone enough. So if somebody asks you, all right, do you need to get a CAT scan on admission to tell me that the patient has acute pancreatitis? No, you don't, right? If you look at it, if you have a characteristic pain and elevated enzymes, that alone meets criteria. You do not have to get a CT abdomen on admission to diagnose acute pancreatitis. That's the first thing I want to engrave into your brains. All right, so now let's move on to physical examination. As you guys already know, one of the most important things that you guys have to learn as an intern is physical examination. Always examine your patients very, very well. All right, so let's see this patient's case. All right, the patient's got blood pressure of 120/70, heart rate of 108, respiratory rate of 24, and a temperature of 99 degrees Fahrenheit. These are all important findings, because the important thing I want to know is the patient is not in shock. However, the patient has a little bit of tachycardia going on, probably because of pain or maybe because of decreased volume in the patient's body. All right, remember acute pancreatitis, right? It's itis, inflammation throughout your body. You're going to be having some component of distributive shock, all right, which can become very, very severe. So there'll be a lot of third spacing when you think of acute pancreatitis. So you have to keep this in mind when you see your patient. So when you look at the heart rate of 108, you must think that the patient is probably going to crash at some point, right? The patient is tachycardic. Now next thing you know, the blood pressure is going to drop. So keep that in mind. Respiratory rate is 24, temperature is 99 degrees Fahrenheit. Now the thing is, fever is another important component you must keep in mind in a patient with acute pancreatitis, but this guy right now does not have fever. On general examination, the guy appears to be in pain. Well, clearly he's got acute pancreatitis. You are going to be in pain, right? If your pancreas is inflamed and swollen, you're going to have a significant amount of pain. All right, so he's in pain. Now let's go to the head, ear, nose and throat, around your face region. What are you looking for? Now the patient with acute pancreatitis by itself, you're not going to see some specific finding, but depending on what is causing it. Now this guy is an alcoholic, right? If he's drinking a lot of alcohol, it's going to be having a lot of liver damage. The moment you have liver damage, you should now think of icterus, right? Presence of jaundice or icterus. You want to see that. Apart from that, because the patient has liver damage, you can have some some coagulation abnormalities, patient could be having some form of chronic blood loss, so you want to look for pallor, right? That's important as well. Apart from that, let's move on to the next part, which is cardiovascular exam. Now cardiovascular exam, patient has S1, S2 heart, no rubs, gallops or murmurs, which is fine, right, in this patient, so that's okay. Respiratory system, normal vesicular breath sounds are heard, no wheezing, no crackles, nothing. However, in patients with severe acute pancreatitis, you can actually go to a point where the patient can develop ARDS, which we're going to get into in a bit, right? So remember, if you're starting to hear crackles all over your lungs or your breath sounds are changing, right, you must keep ARDS in your mind. Alright, then finally let's come to the most important part, which is in fact going to be your abdominal exam, right? So on abdominal exam, now careful when you palpate this person's abdomen, because you're not going to go right in and push on the place where it's most tender. Always start from the furthermost place and get to the most amount of pain area at the end. Alright, so this patient has an epigastric tenderness. Epigastric and mid-abdomen, you're pressing down and you feel pain. Now epigastric tenderness could mean gastritis, right? It could mean gastritis. However, this patient, you must remember, even central abdomen, you must have acute pancreatitis in your mind. Now apart from that, he's got a hepatomegaly. Why? Because the guy is drinking, right? He's got splenomegaly. Again, why? Because he's drinking. If you do some percussion, you will find a dull note, all right? A dull note essentially suggestive of ascites. And apart from that, Murphy's sign, which is negative. Now remember, Murphy's sign is a very specific finding for what? For acute cholecystitis. Alright guys, so the patient with acute pancreatitis, even though it's just the pancreas, don't only focus on the pancreas, look all around, because there are a number of different things that can be causing acute pancreatitis. So you will always look for stigmata of liver failure, right, splenomegaly, and all the complications of acute pancreatitis. Alright guys, so this is your physical examination. Important part. Once you get your physical examination good, you are obviously going to your next part, which is going to be labs and orders. You guys already know how important labs and orders are, right? As an intern, this is where it gets tricky, because you need to know what tests you're going to order, right? Because your senior resident is going to be like, have you ordered the labs already? And you should know, yes, I have ordered the labs, and you should know exactly what labs you're going to order. Now this is how you're going to do this. All right, let's crack this out. So first off, you're going to do a CBC. Now remember, always know why you're ordering a test. Don't just blindly order a test. There's no such thing as a routine test. Alright, so first off, you're going to look at the patient's hemoglobin, and I want to put hematocrit as well. And recall now, I want you to focus that the hematocrit is actually in blue because it has more important significance. Alright, so what happens with a patient with acute pancreatitis, as I told you before, is going to be a lot of third spacing. If you're third spacing, what's going to happen to your blood? It's going to get all hemo concentrated, right? So what's going to happen is your hematocrit is actually going to go up. So hematocrit is actually a measure of your patient's severity of acute pancreatitis. So hematocrit is one thing that's going to predict prognosis. Okay, so for that reason, I'm going to put it in blue. Number 3, you're also looking at platelets. Now remember, when somebody is consuming a lot of alcohol and if it damages the liver, what does the liver produce to stimulate platelet production? Thromboplastin, right? So if you have liver damage, you'll have less thromboplastin, so the patient can actually have a decreased platelet count. There's another reason as well. When you have hepatomegaly, you can also have splenomegaly. And if you have splenomegaly, spleen loves to eat platelets. Yes, so there are 2 reasons why you can actually have thrombocytopenia. So that's your CBC right there. So let's move on to the next one. Now CMP, complete metabolic panel. As you see again, you see BUN and creatinine. Both of them are in blue. Why? Because they are also gonna basically be able to tell you what the severity is. Alright, it's a measure of prognosis. So it's important. BUN and creatinine. Now BUN creatinine actually will be going up. The reason is, again, if you have some form of distributive shock, right? If you have less blood flow to your kidneys, what is it going to cause? It's going to cause some amount of acute kidney injury, right? And if it's much more worse, you can actually have acute tubular necrosis, right? It can be actually much worse. So BUN creatinine is a key critical lab test that you are going to do in a patient with acute pancreatitis. Alright, then you got calcium. Now calcium doesn't tell you what the prognosis is, but if you recall, remember the bone in the hand, right? Hypercalcemia. So hypercalcemia can actually cause acute pancreatitis, so you want to get calcium levels. Then you have your AST, ALT, ALP, GGT and bilirubin, essentially telling you is there liver damage or not? And if there was a liver damage, you guys already know the ratios as to how to measure and tell me, okay, is it because of viral hepatitis, or is it an alcoholic pattern, or is it drug induced? We'll get to that in a different lecture, but for now you must get these tests because it's going to tell you if the patient has liver damage or not. Alright, then you're going to get a CRP. Now C-reactive protein, right? C-reactive protein is a marker of inflammation. When a patient has acute pancreatitis, there's release of interleukin 1 and interleukin 6, both of which is going to stimulate the liver and produce a large amount of CRP. Now CRP again is a measure of prognosis and severity. So I want you to remember these four: hematocrit, BUN, creatinine and CRP. These tells you how severe the patient's condition is. Alright, so that's going to be important. Then PTT, PT, INR. The reason I want PTT, PT, INR is because if you drink alcohol, that's going to cause what? It's going to cause liver damage. If you have liver damage, what's going to happen to coagulation profile, right? Think about if you have liver damage and if you're not producing coagulation factors, you can actually have prolonged PTT, prolonged PT and INR, right? So a patient can become coagulopathic, and you need to figure this out too. So you need that test for sure. Next, oxygen saturation. Now if you see the patient and the patient looks hypoxic, right? It's looking like he's in respiratory distress. You get a pulse oximetry and you see his saturation is going down, right? Less than 88, 87. At this point you must get a arterial blood gas, not a venous blood gas, but an arterial blood gas, because you want to see if the patient is truly hypoxic or not. Now if you recall correctly, go back to your basics, go back to your step 1, step 2. If a patient has acute pancreatitis, what can it cause to the lungs? Can it cause ARDS? Yes, it could, right? So if you have ARDS, you're going to have the saturation to be dropping, and how are you going to define ARDS is based on your ABG, right? It's basically PaO2 levels divided by your FiO2. So for that reason, you are going to require an ABG. Next, you are going to get a lipid panel. What's the reason for the lipid panel? You recall the burger? What was it full of? Triglycerides, right? Now triglycerides actually cause acute pancreatitis. How they actually cause acute pancreatitis is that triglycerides, when they come into the liver, right, it's going to go into your gallbladder to be emulsified and be absorbed and all those things, right? Now what happens is your triglycerides, when they are in your biliary tree, because of the presence of bile, what happens is it breaks down your triglycerides. Once you break down triglycerides, you release free fatty acids. And guess what this free fatty acid is going to do to your biliary mucosa? It's going to cause inflammation. Imagine it causes some inflammation, redness, and next thing you know, it's occluding it. Causes increased back pressure to the pancreas, autodigestion begins. So hypertriglyceridemia breaks down to cause free fatty acids, which is going to cause inflammation and acute pancreatitis. So that's your mechanism of action. So remember why you're learning something. So triglycerides are going to be very important, so get your lipid panel. And it's also going to affect your management, which is really cool, and you guys are going to learn it today. Alright, then you're going to get an EKG, because the reason is some patient is coming to you with acute abdominal pain. Remember, chest pain could always be presenting just like an abdominal pain. So any older gentleman, you must always make sure you get an EKG to rule out acute myocardial infarction. Alright, next, if the patient's blood pressure is low, right, if he was hypertensive, which will happen in patients with acute pancreatitis, you must get a lactate level. Because what is a lactate a measure of? Lactate is a measure of hypoperfusion. If there's elevated lactate, then you know you need to give this patient a lot more fluid. So I've told you guys already what lab tests you're going to order in this patient. Wait a second, am I missing something? I am, right? Remember I told you a diagnostic criteria was what? Amylase and lipase. Alright, so good if you guys were actually following to see if I was making a mistake or not. Amylase and lipase levels, right? These are diagnostic criteria, do not have any form of prognostic indication, but amylase and lipase has to be taken into account, right? And remember, how much should it be? It should be greater than 3 times upper limit of normal. Right? Now this is how you're going to tell if the patient has acute pancreatitis or not. Amylase and lipase, it becomes such an important test. Alright, so make sure you guys never ever forget amylase and lipase in these patients. Alright, so now let me ask you a question. You have this patient who's coming with abdominal pain and you have elevated amylase and lipase. Do you have to get a CT abdomen on presentation? Please tell me no, you do not have to. If a patient is coming with a characteristic epigastric or central abdominal pain radiating to the back, you are so sure this is classic presentation of acute pancreatitis. You get an amylase or a lipase level and it's actually elevated greater than 3 times the upper limit of normal. That alone meets criteria 2 out of the 3, right? It's done. You are done. You don't have to get a CT abdomen on initial presentation. However, if you are in doubt, if the patient's presenting not with the most characteristic abdominal pain, you get an amylase lipase, yeah, mildly elevated, not really suggestive. At that point, when you are in doubt, yes, you can go ahead and get your CT abdomen at that point. But do not ever do it if you're so sure it's acute pancreatitis. You don't need to diagnose it. All right, 2 out of the 3. So CT abdomen is another test, as I told you. Initially, if you're in doubt, you will order a CT abdomen. But if not, the main time you're actually going to do a CT abdomen is in about 72 hours. If the patient's symptoms are worsening, your treatment's not working, at that point you will get a CT abdomen because you're looking for complications of acute pancreatitis. Alright, so CT abdomen becomes very relevant most of the time at about 72 hours. So we'll get into assessment and plan. I'll explain that further. Now, ultrasound abdomen. Ultrasound abdomen is a test you're pretty much going to do on all patients with acute pancreatitis. If you have a clear-cut reason, like this guy who's coming with alcohol consumption, right? If you know for a fact that the alcohol is causing acute pancreatitis, yes, you can go ahead and not do an ultrasound. But because gallstones are such a high incidence of causing acute pancreatitis, is one of the most important causes. So pretty much everybody is going to get an ultrasound abdomen because you have to see if the patient's got gallstones or not. Alright guys, so this is your labs and orders. You've understood what you're ordering, why you're ordering, and when you would order it. This is it. Once you know this, you are set for your internship. So let's go into the assessment and plan. Alright guys, so assessment and plan. As you guys already know, assessment and plan is the most crucial part, right? So based on the history, physical exam, labs and orders, you guys already know this is acute pancreatitis. Fine. So we've got up to this point and you guys have already understood what you're doing before this and why you were doing it. Fine. Now you have a diagnosis of acute pancreatitis. Now, management really depends on how severe the patient's symptoms is, right? Because as I told you, the patient with acute pancreatitis is going to be having some form of distributive shock, right? And as a result, which means shock means patient needs to go to ICU, right? Whereas if the patient is having mild to moderate acute pancreatitis, you could still manage the patient on the floor. But if the patient is more severe, then goes to the ICU. So the real way you're actually going to figure this out is by using a scoring system. Of course, there's a scoring system, right? There's a scoring system for everything. So clearly there's one for this one as well, and it's called Modified Marshall Scoring System. Now I'm gonna show you a table right after this which you can memorize on your own time, but for now I just want to go over what it is really about. Now the 3 things basically present in the Modified Marshall Scoring System is your respiratory, serum creatinine, and cardiovascular. 3 things, that's it. Alright, so respiratory, what we're looking for is a PaO2 over FiO2. What does it tell you? Who defined that one? It was called your Berlin's definition, right? ARDS. If you look up Berlin's definition of ARDS, your PaO2 over FiO2 ratio less than 300 is the beginning of ARDS. So essentially what you're looking for is by using the ratio, if you're having lower and lower PaO2 FiO2 ratio, for instance 300, 200, 100 is becoming more severe, right? So as you go along, in that sense, you're going to get point system for this. You're going to get a certain point if it was if the patient is having worsening PaO2 over FiO2 ratio. Fine. What about creatinine? Again, as I told you, patient can become hypotensive. It's going to cause a pre-renal type of acute kidney failure, or it could even cause an intrarenal type of acute tubular necrosis. So essentially there can be increasing creatinine, right? The worse creatinine gets a higher point. Simple, that's it. Thirdly, you got cardiovascular. Now cardiovascular, if the patient is hypotensive or not, is the patient responding to fluids, is the patient not responding to fluid, is the patient in overt hypotension requiring pressors, right? So that's it. Basically you're going to use your Modified Marshall Scoring System and you're going to tell your senior, listen, this person has a score of 2 or more and therefore he has to go to ICU. So that's the number, 2 or more. If you have at any point 2 or more, that means the patient is having very severe symptoms and therefore needs to go to ICU, and it's not going to be a floor admission. But if the score is less than 2, patient is not having such severe symptoms, this is moderate to mild acute pancreatitis, you can manage the patient on the floor. That's it guys. So to assess severity you need 3 things: PaO2 over FiO2 ratio, serum creatinine, and blood pressure. That's it. It's that simple. Alright, so once you've decided within acute pancreatitis, you decided, okay, is it severe or not? If it is severe, ICU. If it's not severe, floor. Simple. Now, let's get into the treatment of acute pancreatitis. Alright guys, so management of acute pancreatitis, it essentially has just about 4 components. It's so straightforward. So look at this now. So the 4 components you must remember is fluids, pain, food, and antibiotics. That's it. Fluid, pain, food, and antibiotics. So question number 1, fluid. What is your choice of fluid in a patient with acute pancreatitis? Are you saying normal saline? If you're saying normal saline, that's not the right answer. It's pretty much only in acute pancreatitis that we actually favor another type of fluid that's often used by surgeons, which is going to be called Ringer's lactate. Now, Ringer's lactate is the fluid of choice in a patient with acute pancreatitis. The reason is Ringer's lactate, if you compare with normal saline, it actually causes decreased systemic inflammatory response syndrome. So it's actually much more beneficial for you to use Ringer's lactate in a patient with acute pancreatitis. So Ringer's lactate is your fluid choice. Fine. So you've got your fluid choice. Next question is how much fluid you want to give, right? So how are you going to calculate how much fluid you're going to give? If you're telling me 250 cc's or 500 cc's, it's not the best way to go about it. You should tell me how many mLs per kg, right? If you look at Surviving Sepsis campaign for management of septic shock, they say 30 mLs per kg in your initial resuscitation. So in a patient with acute pancreatitis, how much is it, right? So if you have a patient with mild acute pancreatitis, your choice of fluid, you already know, is Ringer's lactate. Your dose is going to be 5 to 10 ml per kg for the first 30 minutes. So 5 to 10 ml per kg. For instance, if you had somebody who's a 70 kilo person, 10 ml per kg is going to be 700 ml. So you're going to give 700 ml to this patient and see the response. Alright, so that's how you're going to do your initial bolus. So you do a bolus first, and then you're going to send the patient on a maintenance dose. So what is your maintenance dose? Your maintenance dose is going to be about 3 mLs per kilogram of body weight. So your maintenance is going to be about 3 mLs per kilogram of body weight for the next 12 to 24 hours. Alright, so the next 12 to 24 hours, you are actually going to give this person 3 mLs per kg. Alright, so that's how you do it. Initially, you want to give a patient a bolus, right? The patient is pretty much going to be hypotensive or is tachycardic, but you know there's fluid depletion in this patient. So you want to give a bolus first, 5 to 10 ml per kg for within 30 minutes, and then you'll do 3 ml per kg for 12 to 24 hours. If you tell me, alright, you know what, the patient is actually in overt shock, it's not a mild to moderate acute pancreatitis, at this point I would even give more fluid. So at this point, if the patient is actually having shock, right, if the patient is in shock, at this point you could do about 20 to 30 mLs per kg for the first 30 minutes. So you can bolus the patient much more. Now if I'm saying 20 to 30 mLs per kg for a person who's 70 kilograms, how much is that? You're talking about at least 1.5 liters to 2 liters. So you're going to give 2 really large boluses to this patient in the first 30 minutes and see the response. And once that's done, you can decide on what your maintenance dose is going to be. Now the thing is, initial 24 hours, your very crucial component of treatment is going to be fluids. You want to resuscitate them as much as possible. Don't fluid overload them, but give them the fluid they need. Reason is, are you telling me, are you going to ask me saying, okay, if you do not give the patient enough fluid, is it going to cause worsening of the patient's symptom? Yes, it is. If you do not resuscitate enough, it actually causes worsening of the acute pancreatitis to become necrotizing pancreatitis. It actually happens. So there's a reason why you actually need to treat these patients with adequate fluid hydration, alright, because it can actually cause the patient to go into worsening necrotizing pancreatitis. Alright, fine. So now it's pretty straightforward. You guys already know how to do the fluid. Your choice is Ringer's lactate. You know to choose your bolus first, and you know what your maintenance dose is. Now another important question is, what about after 24 hours? How are you going to assess to see if the patient is getting enough fluid? Are you still going to go based on 3 ml per kg? No. When it comes to that point, you're going to follow certain parameters. You're going to see the patient's urine output, right? You ideally always want to maintain your urine output greater than 0.5 cc's per kilogram of body weight. May it be septic shock, any type of shock, you want to have this as your magic number. Your urine output should be greater than 0.5 cc's per kilogram of body weight. So if it's the same 70 kilogram person, you're talking about 30 cc's of urine per hour. That tells you you're adequately resuscitating them. You could see the patient's hematocrit in this patient, right? You can also follow the patient's BUN. You can see the response of the patient's blood pressure. So you're going to see all the parameters and decide how much fluid you need to give further or not. All right, so fine. So you know how to manage the patient with fluid hydration, but the story still does not end here. Now the question: when would you not use Ringer's lactate? Is there a contraindication for you to use Ringer's lactate? Yes, there is. Remember one of the causes I told you which would cause acute pancreatitis? Hypercalcemia. Hypercalcemia, you should not use Ringer's lactate. You know why? Because it contains almost 3% of calcium. That's why. Ringer's lactate contains almost 3% of calcium. So if somebody is hypercalcemic causing acute pancreatitis, you're giving the patient more calcium. So this is pretty much the only time you'll actually avoid Ringer's lactate, and in place you're going to do normal saline. You could do normal saline if the patient has hypercalcemia. Alright, so I hope you guys got that. So fluids, this is it. If you know this much, you know as much as your senior resident now. So you're perfectly good. Alright, so let's move on to the next topic of interest, which is going to be pain management. Alright, so pain management, for the longest time there has been an interesting and a very fun story. What people used to tell us was, if you use morphine, right, opioids, you guys already know, it causes constipation, it causes urinary retention, it prevents your sphincter of OD to not work, right? So there was an ancient belief saying that, all right, so let's not use opioids in patients with acute pancreatitis, especially it's going to cause back pressure and cause worsening of symptoms. But there has been no studies to prove this fact. All right, so therefore using a medication such as hydromorphone or fentanyl is perfectly fine. So the whole ancient myth is not actually true. So you can actually go ahead and treat the patient with hydromorphone, or if the patient has some form of renal dysfunction, you could use fentanyl. Either way, you could use either one of these choices, perfectly fine. All right, so you will use opioid. Don't go by the ancient myth anymore. And one more thing, back in the day they used to also say there was a medication called meperidine. This was another opioid, but it did not affect your smooth muscles of your sphincter of OD, and therefore it did not have that side effect. So can we use that? Yes, this was the previous understanding, but no, you cannot use this medication. Reason is this: first off, opioids have not proven to cause acute pancreatitis. That's number one, so that doesn't exist. Number two, meperidine gets metabolized to a medication or a substance called normeperidine. So meperidine becomes normeperidine, and guess what that causes? It causes seizures. So there's a lot of side effects involved with that medication. So therefore we don't use this one. Instead we go on with our good old opioids. All right, and opioids are perfectly fine for acute pancreatitis, and that's exactly what you're going to use. And ideally the way to go about it is a patient adjusted pump. All right, the patient could inject the amount of dose they need based on the amount of pain they have. So that's how you're going to use hydromorphone or fentanyl. Fine, fluids is done, pain is good, patient is feeling better. Now the question is with regards to food. Are you going to feed your patient? The question is pretty simple. Think about it. If a patient's coming to you, clearly the patient is having nausea, vomiting and throwing up a lot, you're not going to feed this patient now, right? You're going to keep him NPO for that point. Fine. But are you going to keep him completely not fed at all? 24 hours, 48 hours can go by, right? So the choice, the way you're going to decide is this: if a patient has no nausea, vomiting and is looking much better, very mild acute pancreatitis, this patient you can start feed right away. All right, you want to start feed right away. But if it is more severe, patient is having nausea, vomiting, not so severe nausea, vomiting but still present, and therefore you cannot tolerate a PO diet, at this point ideally it's best to go with the nasojejunal tube, or you could put in a nasogastric tube and start patient on feed within the first 24 hours, because it actually has benefits of feeding these patients. And if the patient is very, very severe and no way you can put food in this method, at that point you can go for total parenteral nutrition, which is going to be via a peripheral access. Okay, it's an IV formulation of nutrition. All right, again we ideally try to avoid PPNs for all practical purposes, because a lot of side effects involved with giving this kind of fluid into your bloodstream, right? So try to give the patient oral food. If you cannot, then you can put an NG tube or a nasojejunal tube and feed these patients. All right, so you already got your fluids, pain and feeding is done. You're doing pretty well. You're treating your patient pretty good. He's pretty happy with your treatment. All right. So number 4, antibiotics. Now, who gets antibiotics in a patient with acute pancreatitis? All right. So if a patient comes with acute pancreatitis, say you're treating him, he's improving. Day 2 is coming along and day 3 is coming along, and the patient suddenly has worsening of symptoms. And I told you at that point, if a patient has worsening symptoms, say 48, 72 hours or any time in between this time frame, what are you going to do? Are you telling me CAT scan? Yes, you are, right? You are going to do a CT scan, and ideally your CT scan should be with contrast. All right, you want to do a contrast enhanced CT scan. You're going to get a CT scan with IV contrast, and when you look at this CAT scan, now you're seeing that this patient has some amount of necrotic pancreatitis. You see that certain part of the pancreas is actually getting necrotic. So there is necrosis of the pancreas. So okay, fine, there's necrosis, but there's no infection, right? Necrosis does not mean infection. So are you going to give this guy antibiotics? Well, no, you're not. You're not going to give somebody antibiotics just because there's necrosis. If the patient has necrosis plus patient's got a fever, elevated white count, sudden drop of blood pressure, and some culture comes back positive, then if there is an identification, if there is a source, if there is some indication that the patient has an infection, it's only then that you will treat them. You don't blindly give somebody antibiotics just because there is necrosis. All right, necrosis plus signs of infection gets antibiotic. Okay, fine. So you can make the deduction pretty easily. So next question is, what antibiotic should you choose? Because you know that pancreas is not very easy to get through, right? You're going to pull out some big guns at this point. So at this point, you're going to call out your big guns such as your carbapenems. All right, you can bring out your carbapenems because they go into the pancreas very well. So carbapenems is going to be used. You can also use fluoroquinolones, or you could use ceftazidime or cefepime plus metronidazole. And again, the reason you're using these medications is because you must know what's the most common organism to actually infect the pancreas, right? So what are the most common organisms? Think about the gut flora, right? That's what actually is going to affect this patient as well. So remember, the bacteria you're trying to target here is E. coli, you have Enterococcus, and you also have Pseudomonas and Klebsiella. So that's it. You're basically targeting these bugs. These are the 4 bugs you want to hit with these medications: E. coli, Enterococcus, Pseudomonas, and Klebsiella, right? And your possible options of drugs are your big guns. You want carbapenem, which could be used by itself, or you could use fluoroquinolones, ceftazidime, and cefepime. As you guys know, out of your cephalosporins, there's only these 2 that actually cover for Pseudomonas, all right? So cefepime plus metro you must combine. So that's how you're going to do it. If a patient has necrotic pancreas present in CAT scan imaging study, at that point, plus if the patient has signs of infection, you will treat the patient with antibiotics. So this kind of concludes the most important components of management of acute pancreatitis. So you know your fluids, you know how to manage the pain, you know when to start the food, and you know when you're going to choose antibiotic and how you're going to treat the patient with antibiotic. Alright, so you could be satisfied with just this information, but you could also be like, no, you already told us that, you know, there was triglycerides and triglyceride caused acute pancreatitis, then the treatment was supposed to be really cool. So you guys have to learn this. What if your patient has elevated triglycerides, right? You guys need to know. So that's what we're going to do now. Alright, so now let's talk about hypertriglyceridemia induced acute pancreatitis. All other treatments do exist in this as well, but something's really cool about it. So let's learn this. Alright guys, so when you're looking at it, right, I'm telling you the patient has acute pancreatitis, and you get a triglyceride level and say it's 1000. That's very, very high, right? Hypertriglyceridemia. And you guys already know the reason and how it actually causes acute pancreatitis. Now the treatment is this. There's about 2 options that you have which is proven to help these patients. So number 1, your treatment is going to be something known as apheresis. Apheresis is like plasmapheresis, but you're basically sucking out all the fat. That's it. Apheresis, apheresis. A lot of hospitals do have it, but some hospitals do not have it. So if your hospital actually has apheresis machine, what you're gonna do is apheresis. Okay, so what are you gonna do? So you do a session of apheresis, and after that you will repeat the triglyceride level, and your goal is to decrease the triglyceride level less than 500. And if the triglyceride level is still greater than 500, what can you do? Well, you can do one more session of apheresis. All right, you can do one more session of apheresis and repeat your triglyceride level, and if you reached your target of triglyceride less than 500, then all and well, that's what you're gonna do. So your first important treatment, if your hospital actually has the facility, you are gonna do apheresis, and after you bring it less than 500, I will tell you what the treatment is in a very short time. All right, so what if your hospital does not have apheresis machine? Are you gonna let this patient die? No, you're not. You have another solution to this problem, and the solution is going to be insulin. Now insulin, the reason insulin works very well in these cases is because of two reasons. Well, number one is insulin causes increased activity of lipoprotein lipase. Now if you recall your biochemistry, you'll know lipoprotein lipase is actually going to cause increased uptake of all your free fatty acid and store them out in your adipose tissue, basically clearing out all the triglycerides and free fatty acids from your bloodstream. So that's one reason. Number two, it also causes inhibition of your hormone sensitive lipase enzyme. Now the hormone sensitive lipase is actually responsible for releasing of a lot of triglyceride and free fatty acids into your bloodstream. So this is what insulin is going to do. It's going to down-regulate your hormone sensitive lipase and up-regulate your lipoprotein lipase. So it's perfectly fine to cause a decreased triglyceride level in your blood, right? So fine. Now the question is, you've understood why you're going to do it. Now the question is how much you're going to start, right? What's your dose? Your dose is going to be 0.3 units per kilogram of body weight per hour, right? You're going to start the patient with an insulin drip, and this patient is going to go to the ICU as well, guys. Okay, so you're going to send this patient to the ICU and you're going to start the patient on an insulin drip. Again, certain hospitals might be able to do this facility in the floors, but again, depends. But the important thing is you need to start the patient on a insulin drip. Fine. Now there's another important thing that you must remember, right? What if the patient has a glucose level between 150 to 200? If a blood sugar level is 150 to 200, what are you worried about if giving a patient insulin? You are worried about causing hypoglycemia, right? And hypoglycemia can cause death, right? So if the patient's blood sugar is between 150 to 200, this patient, you must also start some fluid which contains D5. All right, you want to give sugar and insulin drip at the same time. All right, so question is, how often are you going to check the finger stick? How often are you going to check the blood sugar? Because what are you worried about? Hypoglycemia, right? So how often you're going to do is every 1 hour. Q1 hourly you will check the patient's finger stick. All right, and apart from that, how often are you going to check the patient's triglyceride? Because your target is less than 500 triglyceride, right? So you'll check it every 12 hours, guys. Every 12 hourly you'll check the patient triglyceride, and your goal is to get less than 500. Hypertriglyceridemia induce acute pancreatitis, either apheresis or insulin drip. Your target is less than 500 triglyceride. Okay, fine. You brought it below 500. What are you going to do next? Are you going to start the patient on an oral medication that primarily is going to decrease triglyceride level? Yes, you are. And what is this medication group called? Fibrates, right? So gemfibrozil. You can start the patient on gemfibrozil, which is very good for the management of these patients with hypertriglyceridemia. So there you go, guys. This is how you're going to treat the patient with acute pancreatitis but has hypertriglyceridemia as the cause for acute pancreatitis. Apart from this part, you are going to give all your fluids, food, antibiotic, and pain management. So this is it, guys. So now you know how to manage these patients with acute pancreatitis. So this completes our lecture on the management of acute pancreatitis. I hope you guys enjoyed this. Alright guys, so this concludes our lecture on acute pancreatitis. There are certain concepts that you guys will be getting questions on in your STEPs exam, especially with regards to what are your scoring system that you could use to identify what the prognosis of the patients are, such as Ranson scoring or Apache 2 scoring. There's also a CAT scan derived scoring system that often the GI attendings as well as the GI fellows are going to be using. Again, we are going to deal with all of these factual stuff in the actual lecture in the GI section of USMLE. For now, I want you guys to focus on the clinical aspect of things, and if you guys know all of this to manage a patient with acute pancreatitis, you are going to be absolutely fantastic. Alright guys, I hope you guys enjoyed this lecture. Please hit the subscribe button and hit the bell button. Therefore, you're going to get notification whenever the new video comes out. So enjoy your studying, and I'll see you guys on the next video.